Online teaching program for postgraduates in pathology 3. So the topic for today is essential of pathology reporting in common GI tumors, and our chairperson for today is Dr. Mahesh Goyal sir, Associate Professor, Department of Surgical Oncology, Tata Memorial Hospital. The speaker for today is Dr. Monika Vyas ma'am, Consultant Pathologist, Beth Israel Deaconess Medical Center, Harvard Medical School, Boston, Massachusetts. Today's moderators are Dr. Nausheen Khan, Professor, Department of Pathology, IIM SR Lucknow, and myself, Dr. Nirmali M. Khound, Consultant Pathologist and Lab Head, IUKD, Guwahati, Assam. The webinar hosts are Dr. Anita Borges ma'am, Consultant Pathologist, Center for Oncopathology, Tata Trust, Mumbai, and Dr. Sumit Gujral sir, Professor, Department of Pathology, Tata Memorial Hospital, Mumbai. These are the reminders. The disclaimers. The upcoming talks, it's on 7th March at 7 p.m. and it is on surgical pathology by Dr. Anita Borges ma'am, Consultant Pathologist, Center for Oncopathology, Tata Trust, Mumbai. And on 12th, we have another talk at 7 p.m. that is Approach to GI Polyps by Dr. Vikram Deshpande sir, Professor of Pathology, Harvard Medical School, USA. So we can start. And Monika Vyas ma'am can start sharing her PPT.
Thank you so much, Nirmali. And thank you so much, Dr. Gujral and Dr. Borges, for having me here. I'm really happy to join today and talk about essentials of pathology reporting in common gastrointestinal malignancies. Trying to advance my screen. Oh, okay. So I have no disclosures. So today we're going to talk about pathology reporting of common gastrointestinal malignancies, most common being adenocarcinomas. So we'll go over the common reporting parameters for these tumors and go over some site-specific considerations as well. And then we will briefly touch upon neuroendocrine neoplasms and reporting of gastrointestinal stroma tumors as well. So one very important consideration when we start looking at a gastrointestinal tract specimen or any specimen from anywhere, any body organ really, is to have a good growth evaluation of the specimen. So key to a good growth, good pathology report is good grossing. So the prosector should know what kind of potential malignancy they're dealing with. If there is a pre-operative biopsy that is available, they should try to go over the report and see what type of malignancy was reported, and then go over the reporting parameters, because while grossing, if they submit appropriate sections, it becomes very easy for the pathologist or the trainee who's evaluating the slides to understand what the prosector is trying to demonstrate. And also taking good quality pictures for people to go back. Once the specimen is grossed, you cannot put it back together. So taking good gross images is also very important. And then lastly, the amount of prognostic factors and reporting parameters is increasing by the day. Every day we have new studies talking about this variable or that variable, which might have a potential impact on patient prognosis. So how do we remember to report all these parameters? So having a nice standardized synoptic reporting template can go a long way in standardizing these reports and making sure we don't miss out on any important reporting parameter. So in the gastrointestinal tract, we see two common types of therapeutic resection specimens. One is your regular surgical resection specimens, example, a gastrectomy for upper GI stomach malignancies, or right hemi low anterior resection for upper rectal cancers. And then we also nowadays see a lot of conservative procedures being done. The impetus is on conserving the organ. So we have a lot of local excision options for early stage malignancies. So endoscopic mucosal resection and endoscopic submucosal dissection are such examples. Polypectomies we've been seeing for a long time now, and transanal excision for early stage rectal cancers also yield specimens on which we do have to provide prognostic information and give margin status. So this is one important thing to remember. So pathology reports from therapeutic specimens should cover these important characteristics. So we definitely have to talk about the tumor characteristics, right? So talk about what type of tumor we're seeing, what's the size of the tumor, what's the extent of involvement, especially like involving the layers of the bowel wall. Then we also comment on prognostic factors such as lymphovascular invasion, perineural invasion, tumor budding, etc. Also, we have to talk about the margin. So in a surgical resection, we talk about mucosal resection margins, proximal and distal. Then depending on where the specimen is coming from in the GI tract, we may have a circumferential resection margin or a mesenteric resection margin. And for the local excision specimens, we'll have the mucosal resection margins and a deep resection margin. And then we also try to comment on the background process. What is the disease, or what is the neoplasm arising in a background of? So it could be Barrett's esophagus, or it could be inflammatory bowel disease, or autoimmune or atrophic gastritis. So we try to comment on the background process because that will predict or give the clinician an idea about what this patient might be predisposed to in the future. So let's begin with the reporting parameters. So we talk about the procedure that was done, and this information is easily available in the operative report. So we try to review before starting the specimen, what kind of specimen are we dealing with. So if we're dealing with a right hemicolectomy, we have to find terminal ileum and open it. We have to see if the patient has their appendix preserved, and then the rest of the colon that is attached. Similarly, in the upper GI tract example, in the stomach, you can have a wedge resection commonly seen for gastrointestinal stromal tumors. Then you can have a central gastrectomy or proximal distal gastrectomy as well. So you definitely do need to know where the specimen is coming from, and that will determine what type of margins you're going to take, what other attached organs you're expecting, and also to a certain extent it impacts the lymph node yield as well. So let's go to some site-specific considerations. So esophagus, as you all are aware from your histology training, that there is no serosa. So the esophagus is invested by a layer called adventitia. So that is an important thing to remember while staging. And we'll go over that in a minute. But a tumor is considered esophageal if it's entirely present in the esophagus with no gastroesophageal junction involvement, or if the midpoint of the tumor is in the distal esophagus and the tumor involves the GEJ, or if the midpoint of the tumor is at the gastroesophageal junction, or if the midpoint is within 2 centimeters in the proximal stomach and involves the gastroesophageal junction. So this is a important consideration. In surgical specimens, the procedure has already happened, so it's a bit, less important. But obviously, you need to know this because you'll be staging the tumor in such a way and using appropriate synoptic reporting template. So a tumor is considered as gastric if it involves the gastroesophageal junction, but if the midpoint is more than 2 centimeters in the proximal stomach, so beyond that 2 centimeter cutoff in the cardia or fundus, And then, or the midpoint is less than 2 centimeter in the proximal stomach, but it does not involve the GEJ. So this is something you can, go back and review while grossing the specimen as well, in order to appropriately designate the tumor as esophageal or gastric. So moving on to the rectum, as you know, rectum is a special portion in the gastrointestinal tract because it's not entirely invested by the serosa. So here, what I'm trying to illustrate is the upper rectum is completely invested by the serosa, except in the posterior part where it's sort of where the rectosigmoid continues with the mesentery. And then in the middle 1/3 of the rectum, only the anterior part has peritoneum. So that is called the anterior peritoneal reflection, the point at which the peritoneum reflects off the rectum and either goes on the uterus or the bladder. So that's the anterior peritoneal reflection, and the middle third of the rectum will only have serosa on the anterior part. And then the lower third of the rectum is completely devoid of serosa. So all you have is a circumferential resection margin. And this is very important while grossing these rectal specimens for two reasons. One thing is we have to evaluate the mesorectum, which I'll come to, and then while assigning a location and staging the tumor. Because as you'll see, tumors in the upper rectum, when they involve the serosa, they become PT4A. And when tumors in the, if the tumor is in the posterior rectum, then it's not related to the serosa. And if it involves the circumferential resection margin, then it's a margin positive status, but still T3. So what is evaluation of mesorectum? So in the last decade, the concept of total mesorectal excision, or TME, has come forth. And what it means is dissection of the perirectal tissue along the visceral plane. um, should You should see this thin film of, a thin layer of connective tissue investing the rectum. So when you see this completely encasing the rectum, there are multiple parameters which you look at. But when you have this thin film or fascia completely encasing the mesorectum, that is most likely a total mesorectal excision. Whereas if you see breaks or discontinuity in the tissue like this, if the bulk of the rectum is moderate, if there is irregularity on the mesorectal surface and defects more than 5 millimeter, but none of them extending up to the muscularis propria, and then you don't see any visible areas of muscularis propria, that is nearly complete. And when you have little bulk, multiple defects in the mesorectum, and also muscularis propria being visible, then you call it a incomplete excision. Now, why is it important? So total mesorectal excision, um, it ensures that your circumferential resection margin is complete. You have removed adequate lymph nodes with the specimen, and also it portends a risk of local recurrence. So it's important to comment on the mesorectum status. And evaluation of TME is done on fresh state, like this type of specimen, and also after fixation, when you cut the rectum in coronal sections, you will be able to see the on transfer sectioning, you'll be able to see the irregularity of the CRM much better. So evaluation of TME is a multi-step process. So moving on to the histologic types. So the WHO classification of each of the parts of the gastrointestinal tract is different. Most common being adenocarcinoma, but then you have a bunch of other histologic subtypes which you need to be aware and classify appropriately. I won't go over each of these, but you can take a look. If you see a deviation from normal histology of adenocarcinoma, it's best to go back to the book and see if your morphology fits into any of the other category better. And when you're obviously trying to give a rare histologic subtype, it's good to so have immunohistochemical support, or you know um, um, show it to multiple colleagues and arrive at a consensus. So here are some examples. So here on top left, we have a routine adenocarcinoma, a moderately differentiated or well differentiated tumor. Sometimes you can see a lot of signet ring cell differentiation, which puts the tumor in a poorly differentiated category. On the top right, I have an example of a large cell neuroendocrine tumor. You can see there is moderate amount of cytoplasm, and the nucleoli are prominent in some of these cells, a lot of apoptotic debris. So poorly differentiated morphology with lots of apoptosis. Always think about neuroendocrine. We always say about neuroendocrine tumors, if you're not thinking about them, you cannot diagnose them. So whenever I see a poorly differentiated morphology, I try to do a P40 to rule out a squamous differentiation, which also portends a poor prognosis, and obviously do neuroendocrine markers to see if this is a neuroendocrine tumor associated with that. And here in the left bottom, we have a poorly differentiated morphology of a carcinoma. Here in the middle,
Ma'am, the
sorry to
picture is not coming, ma'am.
Ma'am, sorry to interrupt. Dr. Sakina, can you please remove your annotation? Ma'am, your screen has stopped sharing.
oh, okay.
You will have to
I'll
reshare.
stop and reshare. Okay, I can do that. Oh, it's not allowing me to stop. Can you hear me?
Yes, ma'am. We
Yes,
can
ma'am.
hear you.
Oh, hang on.
Ma'am, now you can reshare.
It's not allowing me to stop sharing. Hang on. Let me do this.
Maybe then, ma'am, if you log out, then again.
Can you see it now?
Yes, ma'am.
Yes,
Now
ma'am. It's visible.
Now you can see it, right? Okay.
Yes, ma'am. Yes.
Where did it stop? Can you tell me? Maybe I can go over
Ma'am,
those
when
parts
you were
again.
explaining this slide itself, after the neuroendocrine part.
Okay. So
Yes.
after neuroendocrine, we went to the lower left image, and that's just a poorly differentiated morphology of carcinoma. You have many differentials there, right? So it could just be poorly differentiated adenocarcinoma, it could be neuroendocrine, it could be squamous cell. So you would do appropriate immunohistochemical stains or look for histologic clues to help you determine if this could be an associated subtype. And then here we have an example of a goblet cell adenocarcinoma, where you see this nice tubular morphology in the center, right here. And then also seen our smaller clusters and single cells. I'm not sure if we can appreciate, but you have singly scattered signet-like cells also. So this is a goblet cell adenocarcinoma of the appendix. And here we have a low-grade mucinous neoplasm of the appendix. You can see a very undulating surface. It is a low-grade dysplastic mucinous epithelium, and you can see that the bases of these glands are directly sitting on the muscle layer. So the lamina propria and muscularis mucosae is completely obliterated, and submucosa is completely obliterated due to pushing invasion of this neoplasm. So here are some examples. Okay. All right. I'm still sharing, right? You guys can see it?
Yes, ma'am.
Okay. So moving on to the histologic grade. So for adenocarcinomas, we also try to grade the adenocarcinoma into well-differentiated, moderately differentiated, or poorly differentiated morphology, and that depends on the amount of gland formation you're seeing. Now, well-differentiated adenocarcinomas have more than 95% gland formation, moderately between 50 to 95, and poorly differentiated less than 50%. We also can have undifferentiated subtypes, which have no gland formation, mucin, squamous, or neuroendocrine features. So that is completely undifferentiated. When you do a keratin, sometimes these can be negative for keratin as well. And it can be very challenging in those situations. We start thinking about whether it could be associated, an INI or BRG1 deficient tumor, or, we escalate the workup to try to categorize the undifferentiated morphology and see if we can find any correlates for that. Now, if you see poorly differentiated features focally in a well-differentiated neoplasm, especially in a local resection specimen, I would still mention it that there is focal either high tumor budding or poorly differentiated clusters, because that could impact the decision making depending on other parameters taken together. So it's always a good idea to mention any poor prognostic factors that you're seeing in the case. So moving on to tumor size, for most GI tract tumors, adenocarcinomas, tumor size does not factor into our T stage, but we have to remember to give it. Anyways, it's an important parameter. It helps us compare, the preoperative impression with what we're seeing in pathology. And also, especially in treated tumors, it's important to know the size of the tumor bed, whether it's been completely sampled or not, because there could be residual carcinoma anywhere in the tumor bed. But it does factor into staging for some other types of tumors, such as anal squamous cell carcinoma, neuroendocrine tumors of some types, and gastrointestinal stromal tumors. So it's an important parameter to note and report. Tumor extent is very important for staging of GI tract adenocarcinomas. So here we have the various layers of the bowel wall. So you can see the mucosa with muscularis mucosae following that, and submucosa, muscularis propria, subserosa, and serosa. And depending on the deepest extension of the tumor that you're seeing in the case, you will assign a T stage based on that. We'll go over various T stage considerations in one of the subsequent slides, but this is a parameter that is extremely important. And it's very important to pay attention to these small crevices that you see in the serosa, because that is most commonly the T stage discrepancy that we encounter, because people are not paying attention to these little divots in the serosa where it dives down. So even if the tumor is involving the serosa in this deep part, you will call it a serosal involvement and PT4 stage. So here's an example. So here again, your importance of your grossing is illustrated to its greatest extent, right? So examination of the external surface, the serosal surface, is very important, because when you see serosal irregularities or puckering, that's the buzzword, like this, or any nodularity there, extremely important to slice it, into thin slices and evaluate where the serosa might be involved. And it's not necessary that in all of this puckered area you will have serosal involvement. It could be very focal in this area. So you need to sample it properly. And wherever you see the deepest extension, if you grossly, you can see obviously tumor, wide tumor extending on the serosa, you would submit that section, submit multiple flanking sections. But what I would do is, if those sections do not demonstrate serosal involvement, or if there's only fibrosis in that area, I would go back and submit the entire puckered area, because involvement can be anywhere in this area. So that is one important thing. And the person who's grossing the specimen has to be aware of this, make you aware of that in their gross description as well. And then this is an example of what I was talking about. This is just a little, area where the serosa is diving down. and the tumors involving the serosa in that part. Having ink on this area can help a lot, because sometimes what happens is the tumor is destroying the serosa. There's a lot of inflammation, and if you don't have the ink, you are not able to decide if that is the true edge of the tissue or not. Having ink there is really helpful. So here are some other examples that we see. Sometimes, as I mentioned with the previous slide, the tumor will completely destroy the serosa, or between the serosa and the tumor, all you have is hemorrhage. So that would also be considered as PT4A. If the tumor involves the serosa in an area of ulceration, so if you have only inflammatory cells between the tumor and the serosa, that is also PT4A. Here, this is a very controversial area. Here we have tumor going right up to the serosa, and I'm very certain that this serosa is involved by tumor in some place, right? So what I do in such situations, but you do see there's like, a couple fibroblasts between the serosa. So some people would argue that this is still T3. In these cases, what I do is do multiple levels, and I think in 99% of these cases, I am able to demonstrate tumor on the serosa. If not, then you could, depending on how confident you are, you could still stage it as PT4 and put in a note that there are the tumors almost on the serosa, but there's only few cells in between, and there is extensive serosal reaction, which makes you feel that this is a T4A tumor, and you're just not able to demonstrate on the slide. Or you could stage it as PT3 and put the same note. So these type of cases will end up on multidisciplinary tumor boards, and we can show these slides to our colleagues, and a adequate management strategy can be devised for these patients. Obviously, macroscopic perforation in the area of tumor would again amount to a PT4. And then it's very important to ink the area of perforation and submit sections which adequately demonstrate tumor at the site of perforation, like we see here in this image. We have some orange ink here and tumor right at the ink. So this tumor has perforated the bowel wall and gone through. So here we have next parameter that we would consider is lymphovascular invasion. So in the GI tract, we talk about small vessel invasion, which is the lymphatic invasion, and large vessel invasion, which is involving the large veins. So lymphatic invasion is easier to diagnose. You see a cluster of tumor cells surrounded by a cleft in a vascular space. You can appreciate some endothelial cells lining the space. So this is an example of small vessel invasion. Having small vessel invasion puts the patient at risk for lymph node metastasis. So here we have an example of a large venous invasion. So a clue to this would be presence of a nodule of tumor next to a thick-walled artery. So that would be a naked artery sign. So if you see an artery without a vein, but in place of the vein, you have a nodule of tumor, that would suggest that this could be large venous invasion. And sometimes you have more linear extensions of tumor going through the muscle wall, which is also called the tongue sign. So that is also one clue that there might be venous invasion. So what you would do in those cases, if you're confident, if you can see some remnant venous wall adjacent to the vessel, you can report it on H&E. Sometimes doing an elastic stain will help demonstrate elastic fibers, investing the wall around the tumor. That will tell you that this is actually
sorry to interrupt you. Ma'am,
Yes.
can you use a laser pointer?
Audience are asking for it.
Oh, okay. How do I change to a laser pointer?
Ma'am, actually, there is a swiggle sign on your screen on the right,
Upper right side.
on your top right corner, I
Okay.
think.
Top right corner, uh, I don't have anything there. In the main window or on the in the slide. Maybe I can exit full screen and then try. Hang on. Okay. Mm. Does anyone know where I can find it? I'm happy to use it. Tools, let's see. Mm.
Ma'am, Bojas ma'am is saying
Full screen,
right
ma'am.
click.
Just make it
What?
full screen first.
Full screen? Okay.
Yeah.
Mm-hmm. Okay. Now
Just
what?
right click on the screen.
Okay. Yeah.
Yeah. There is a pointer option.
Okay. Got
Just
it.
take a laser
Okay.
pointer.
Okay.
ma'am.
Is this
Thank
good?
Thank
Okay. So sorry
Yeah.
about that.
No, no, ma'am.
Okay. So we talked about large venous invasion. So we really care more about extramural large vessel invasion. So extramural means the focus is present in the pericolic fat beyond the muscularis propria. So that has been shown to have a risk of liver metastasis. So we definitely want to report on extramural large vessel invasion. Intramural also you.
There is another request. Please repeat from the large vessel invasion point. Please repeat from the large vessel invasion point. They want you to repeat the large vessel invasion point.
Okay, so we talked about small vessel invasion, which is involvement of lymphatics by tumor. And so next thing is large vessel invasion. So what offers you a clue that there might be large vessel invasion is presence of these naked arteries. So you see a thick walled vessel, but there is no accompanying vein next to this vessel. So we can't explain that, right? Where's the vein go? But then if you have a tumor nodule next to this thick walled artery, then that means that it can potentially be a vein which has been completely destroyed by the tumor. So that is large venous invasion. So if you see a remnant vessel wall, then you're done. You can report it on H&E. But if you don't and you're not confident that this is large venous invasion, then what you can do is do an elastic stain. An elastic stain will help you demonstrate some broken elastic fibers around the tumor nodule, which will prove that this was actually a vein at some point and now has been destroyed by tumor. So large vessel invasion can be in the submucosa, muscularis propria, or beyond that, right? So when you have large venous invasion involving the submucosa or muscularis propria, that is called intramural large vessel invasion. And that, even though significant enough to report, is not shown to be that prognostically significant. However, when you have large venous invasion beyond the muscularis propria, so involving the pericolonic fat, then that is called extramural large vessel invasion, and that has been shown to have a risk of liver metastasis. So you definitely want to report that. So one common strategy that many pathologists employ is whenever you see a T3 tumor, that is a tumor which is going beyond the muscle layer and involving the pericolic fat, you do an elastic stain on those blocks and see if you can find any extramural large vessel invasion. It's not completely justified. Some pathologists also try to do it if they have a suspicion of large venous invasion, and that's fine too. So next parameter that we can talk about is perineural invasion. Again, a parameter that is associated with poor prognosis in colorectal cancers and gastrointestinal cancers. So common place to look for perineural invasion would be around the mesenteric plexus. So if you follow the tumor along between the longitudinal and circular muscle layers of the muscularis propria, you will often find tumor extending along the nerves there. So that is perineural invasion, but you can find perineural invasion in the pericolic fat also anywhere in the tumor, but this would be a common location to watch out for. So next we go to tumor budding. So tumor buds are defined as either single cells or small clusters of tumor cells, less than 5 cells in number, at the advancing front of the tumor. So that is also shown to be an adverse prognostic factor associated with a higher risk of lymph node metastasis. So the way we assess for tumor budding is you'll scan all your tumor slides at 20x and try to find hotspot areas for tumor budding. And then once you have found some of your hotspot areas, go and count for tumor buds in this area on 20x. So one important thing is to only do the tumor bud count on H&E sections. It is tempting to do it on, if you have a keratin stain done for some other reason, you might want to, you might be tempted to look at that and count tumor buds there. But that is not how the prognostic studies were done. So we have to follow the methodology that was followed in these studies. So we only do the count on H&E stained sections and do not use any immunohistochemical methods to aid the counting. So the once you have your highest tumor bud score for that particular tumor, you can categorize that into a low, intermediate, or high tumor budding score. So having 0 to 4 buds in the 20x field would put it in the low category, 5 to 9 in intermediate, and more than 10 in high category. Some situations make assessment of tumor budding very challenging and even unreliable. So if you have a lot of inflammation at the advancing front, your tumor budding is not going to be very reliable. So in such cases, you can refrain from giving a score and put in a comment that tumor budding could not be performed due to extensive inflammation at the advancing edge of the tumor. Again, do not use the immunostain slide. Medullary or micropapillary carcinomas subtypes, again, you cannot do a tumor budding score. Medullary, because they have a pushing invasion, they don't have an infiltrative edge, so you don't have tumor buds, and not having tumor buds doesn't really, translate into that type of prognosis for this histology. And also micropapillary carcinoma, because, presence of multiple papillae, micropapillary areas would confound your tumor budding score. Also, in a post-neoadjuvant setting, your tumor budding score might not be reliable. There are some papers which do talk about tumor budding and in treated cancers as well. So if you do wish to give a tumor budding score, please mention that this has been performed on a treated case or post-NACT case. So moving on to treatment effect, not uncommon to see treated tumors these days, right? So, and it becomes very difficult to grossly evaluate for tumor after a tumor has been treated preoperatively. So if macroscopic tumor is not present, we advise submitting the entire tumor bed, because you never know where residual tumor will be in that fibrotic area. And then there are some treatment related changes which you need to be aware of. So you'll see stromal fibrosis, presence of acellular mucin pools, inflammatory cells, and then the tumor morphology itself can undergo alteration. So if you compare that tumor with a preoperative biopsy, you may find that the morphology looks slightly, oh, it stopped sharing. Hang on. I don't know why. Do you see my screen?
No, ma'am, it's not visible now, your screen.
Okay, I don't know why it's dropping.
I think, ma'am, people are putting up annotations. Because of that, it is getting interrupted.
Okay. Do you see it now?
Yes,
Yes,
ma'am.
ma'am, we can see.
And it's important to identify these treatment-related changes because it helps you identify the tumor bed, right? So when you don't see a microscopic tumor, it's difficult to know whether we have sampled the tumor bed or not. So especially for small tumors, that might be a consideration. So seeing these changes will help you understand that we did sample the right area, but we don't have residual tumor. And then obviously, these changes are also good to identify when you're doing a tumor regression score. So there are various schemes for doing a tumor regression evaluation. So we follow the modified Ryan scheme. There's the CAP one and MSKCC one, and you can choose whichever one you want based on your understanding with your treating physicians. So here we have a case illustrating complete response. So what you see is just this stromal fibrosis and inflammatory cells here. So you know that this is the right area. This is not your normal histology of the GI tract there, but we don't see any viable cells, so that is designated as complete response. Sometimes you can see extensive pools of mucin, and then you'll have small clusters of tumor cells in these pools of mucin. So single cells or rare small groups of cancer cells would put it in a near complete response. Then you can have residual cancer, a good amount with evident tumor regression, but the amount of residual tumor is more than just single cells or few clusters. So then that is considered as partial response. And then you can have extensive tumor. You will see some type of background fibrosis in these cases as well, but it's hard to identify whether it's the desmoplasia, which has been elicited by the tumor, or it's some type of treatment-related response. But you have extensive tumor present, which will put it in poor or no response category. So next we come to the precursor lesion. So a lot of times with gastrointestinal carcinomas, the carcinoma will completely overgrow the precursor lesion, and we can't identify whether this was arising in a tubular adenoma, tubular-villus adenoma, or a serrated polyp. But sometimes you can, identify, and when you can, it's good to note what type of tumor it's arising in. So coming to the margins, one of the most important parameters while evaluating. So standard surgical resections for gastrointestinal malignancies will have two mucosal margins and a radial margin. So the mucosal margins would be where the organ has been cut from the body. So the rest, your standard specimens will have one proximal mucosal margin and one distal mucosal margin. And where the tumor is, where the specimen is cut from the mesentery, that would be a mesenteric resection margin. Now, some parts of the GI tract are not invested by serosa completely, right? So on the right side, you have areas where the bowel is completely sitting on the retroperitoneal soft tissue without a layer of serosa. So that is where the surgeon will have to go around the soft tissue and cut it. So this would be a specimen that's partially invested by serosa. So it will have a serosal edge, and it will also have a radial or circumferential margin. Now, in the rectum, the lower rectum, as we discussed, is completely devoid of serosa. So what you will have is a circumferential resection margin or radial margin. And then some parts of the bowel have serosa encasing almost complete circumference of the bowel, with only an area where it reflects on the mesentery. So that would be your bare area or the mesenteric resection margin. So very important to know again what kind of surgery the surgeon has done in order to plan how you're going to evaluate and take your margin sections. So here are some examples. So this is a rectal cancer specimen. So we have a proximal margin and a distal mucosal margin here that I've labeled. And then we have this portion which is inked with blue ink here. And that is the part where there is no serosa. So it's the soft tissue which has been dissected along the visceral plane, and relationship of the tumor to this soft tissue edge would be a circumferential or radial resection margin. And similarly, this is coming from somewhere in the upper part of the GI tract, where you have the mesentery. So this is your mesenteric resection margin, and then you will again have two mucosal resection margins. So margin status, people report them variably, but if all your margins are negative, then it's good to give the closest margin, the distance from the closest margin, and also distance to the radial margin for rectal specimens, and distance to the distal margin again for rectal cancer specimens. And if positive, definitely you want to specify all the positive margins. For rectal cancers, we follow a 4-color ink protocol, which helps us identify ink colors and orient ourselves to which margin is closest or positive. But you can either do it that way, or you can have clear, a section key specifying which sections are taken from which part, and that way you don't have to do wholly on the specimen. So you can have an approach which works best with your trainees and labs. And then we also try to comment on the status of dysplasia at the margin, so whether there's high-grade dysplasia or low-grade dysplasia present at the margins. So moving on to the regional lymph nodes. So what are regional lymph nodes? Regional lymph nodes are the lymph nodes which are draining the area of the tumor. So those are the local lymph nodes, which are the first line of defense against the tumor. So your first metastasis is likely to occur there. So depending on the organ involved, you will have different groups which might be designated as regional for that site. So again, important to know what type of specimen it is and what would be the regional lymph nodes for that particular site. So again, depending on the part of the GI tract, we have a minimum lymph node requirement for adequate evaluation of a surgical specimen. So presence of X number of lymph nodes not only is important from staging perspective. If we don't have 12 lymph nodes in colorectal cases, or 16 in upper gastrointestinal cases, it means we cannot adequately give an end stage. So it is definitely important from staging perspective, but it also has been shown to have prognostic implications. So patients who've had more lymph nodes harvested from their colorectal specimens tend to do better. So it's also a prognostically important parameter. And we definitely take this very seriously and try to regrow the specimen, go back to the specimen and submit more tissue if we fall short of lymph nodes. And this is done upfront for any case which might be less on lymph node numbers. So we try to report the number of lymph nodes which are positive, and also the total number of lymph nodes examined. And sometimes you may feel that you have 12 lymph nodes and you've met the requirement, but then the surgeon will come back and say that, oh, for this case, I had done a high ligation and I expect more lymph nodes. And it's prudent to go back, because again, it's not just about, finding 12 lymph nodes, it's trying to sample all the lymph nodes. So whenever we are, talking to trainees, the emphasis has to be on you try to submit all possible lymph nodes and not just, try to reach a number and stop. So that is something, it's a very common misconception. And it's important to re-emphasize this with the prosector so that they don't stop at the given number of lymph nodes. So moving on to tumor deposits. So tumor deposit is nothing but a focus of tumor in a pericolonic fat away from the main tumor. So it's not continuous with the tumor, and even if it's present in the vicinity of the tumor and not directly continuous, it may be connected in some plane. So if you have that kind of a doubt, it's always good to do additional level submit sections and make sure that what you're dealing with is an actual tumor deposit and not just an extension of the tumor. So tumor deposit, while calling something tumor deposit, you have to make sure that you don't see a visible rim of lymphoid tissue or a capsule around that deposit, which would make it a lymph node met rather than a tumor deposit. You don't see any vascular structure involved, or you are excluding perineural invasion as well. So you don't see a nerve at the center of the tumor deposit, because all of these again will have different meanings. And so, but having said all that, finally, what a tumor deposit probably is a lymph node which is completely effaced by tumor, or it could be a vessel which is completely destroyed by the tumor, or it's perineural invasion with the nerve completely destroyed by the tumor. But as long as we can place a deposit in one of these categories, we don't call it a tumor deposit. You would designate it as such, depending on the underlying process. When you really can't tell what the process is, then you call it tumor deposit. And that is important because presence of tumor deposit in absence of lymph node metastasis would place the tumor in a N1C category. So it is important from staging point of view. And then distant metastasis, usually we don't have a way to comment on that. So we say not applicable unless you have a small piece of liver or a liver biopsy that's been done in the same sitting, and you can demonstrate that there is metastasis. Or if you have during surgery, if the surgeon comes across non-regional lymph nodes which were enlarged and submits those to you, then you could definitely call it metastasis. But otherwise, in most of our specimens, it's hard to comment on distant metastasis. So moving on to path stage. So we talked a little bit about this. So the T stage depends on the extent of invasion of the bowel wall for all of the tubular GI organs, except for anus, where the stage depends on the size of the tumor. And PT4 designation is differently applied depending on the peritonealization status of the organ. So what I mean by that is when you have an organ, say on the left side, which is invested by the serosa, and you have the tumor involving the serosa, then that is a PT4 stage. But in a portion where you do not have serosa, like in the lower rectum, then presence of tumor on the circumferential resection margin, that does not make it a T4 tumor. It only makes it a T3 because it's still in the pericolonic tissue, and it is considered a positive margin if it involves the CRM. So for these cases, only if the tumor is invading the adjacent structures, you can use the designation PT4. So here's a little, overview of staging parameters for various locations in the GI tract. I will not go into all of the details here, but just so that you're aware, in the upper GI tract and lower GI tract, the PT1 stage is done differently, and we'll talk about that in the next slide. So definitely something you need to be aware of. PT1 is submucosal involvement in the lower GI tract, whereas in the upper GI tract, invasion of the lamina propria or muscularis mucosae is considered PT1A, and presence of tumor in the submucosa is PT1B. And So, an end stage also depends on the number of lymph nodes involved, and that is, variably described for different areas of the GI tract. So, always a good idea to have a synoptic report with these parameters inbuilt, or having your AGCC staging manual handy while dealing with these. Another organ that is special is appendix, because staging for appendiceal neoplasms, especially the low-grade appendiceal mucinous neoplasms, is not same as adenocarcinomas. So you do not have a PT1 1 and PT2 stage there. So any tumor which is involving the structures before muscularis propria is still considered as PTIS. So definitely have that handy while staging your lamins. And yeah, I think that's it about. And for the esophagus, since there's no serosa, presence of tumor involving the pleura or pericardium, diaphragm, or peritoneum is considered PT4A, and presence of tumor involving aorta, trachea, or the vertebrae is considered T4B. So a little bit about the PTIS, or intramucosal carcinoma designation, in upper and lower GI tracts. So in the lower GI tract, when the tumor involves the lamina propria or muscularis mucosae, but not extending into the submucosa, it is still called intramucosal carcinoma and given a PTIS stage. And the reason for that is there are very few or no lymphatics in the lamina propria in the lower GI tract. So the risk of lymph node metastasis for tumors involving these structures is minimal to none. And hence, a more conservative approach might be okay for these tumors. In the upper GI tract, the lamina propria does have lymphatics. So involvement of the lamina propria muscularis mucosae is not considered PTIS. It is staged as PT1A, as we saw in the previous slide. And PTIS only means intraepithelial tumor without invasion of lamina propria. So it's essentially high-grade dysplasia is called PTIS, or carcinoma in situ. So that is one difference which is important to remember. And it's not uncommon to see lymphatic involvement in very early stage upper GI adenocarcinomas, which we get EMRs and ESDs for. So it's definitely something that makes a lot of sense. So additional findings to note would be presence of a precursor lesion or background process, such as inflammatory bowel disease or diverticulosis, H. pylori or trophic gastritis, which definitely need to be treated so that the patient is not predisposed to further sequela of these processes. And then we also tend to do mismatch repair IHC on all of our gastrointestinal tumors, and molecular testing for KRAS, NRAS, and BRAF when indicated, and HER2 IHC for upper GI tract cancers. So mismatch repair IHC is fairly simple to interpret. There are many caveats which I will not go into, but really what you're seeing is loss of nuclear staining. So in this case, what we are seeing is there's loss of MLH1 and PMS2, because here, even though there is a high background, you can see there is no nuclear staining, and then the internal control in the stromal cells shows nice nuclear staining. So this is interpreted as loss of MLH1 PMS2, whereas there is intact nuclear staining for MSH2 and MSH6. So here's the interpretation of MLH of MMR IHC. So intact nuclear staining for all of the 4 proteins is interpreted as normal. When you have loss of MLH1 and PMS2, it's likely related to MLH1 promoter methylation or a BRAF mutation. So that's the most common scenario, and that is seen in sporadic tumors. You can also have double somatic mutations in MLH1, again a sporadic situation, And then you can have germline mutations of MLH1 as well. When you have loss of MSH2 and MSH6, then it's more, then you go down the genetic counseling route, and you have to look for MSH2 germline or double somatic mutations, or presence of EpCAM mutation, presence of PMS2 or MSH6 losses are associated either with germline mutation of these respective proteins, or missense mutations in the associated major proteins, so MLH1 for PMS2 and MSH2 for MSH6. And then certain special situations such as post-treatment cancers can show MSH6 loss, presence of MLH1 and PMS2 loss along with MSH6 loss would mean that the MSH6 loss is secondary to mismatch repair deficiency and microsatellite instability, which was introduced by the MLH1 defect. So you need to be aware of those type of special situations as well. And then HER2-IHC, it's really a little troublesome to interpret, and you have to know your stain, how it works, how your control worked that day. So the criteria are slightly different for surgical resection specimens and biopsy specimens. So depending on the amount of tumor, which shows either weak to moderate or complete staining, you would score the HER2-IHC as 1+, 2+, or 3+. So a 10% cutoff has been established for surgical specimens. But for biopsies, even if you see weak or moderate staining, or either complete or basolateral or lateral membranous in a percentage of cells, usually you need it in a small cluster, so up to 5 cells, even if you have strong staining in that, you can call it positive. So any equivocal staining or 2+ staining would trigger a request for HER2 FISH. And for score of 0 or 1+, you don't really need to do FISH. So going to the local excision specimen, and I'll try to speed up a little in the interest of time. So again, these are small specimens which are resected with a curative intent. So our responsibility in these cases is to report on the tumor and the margins as well. So EMR, ESD, ampulectomy, polypectomy, and transanal excision are some examples. So again, you have to give the tumor type and grade, size, extent in that particular specimen. And even though you will not have the full thickness of the bowel wall, you can report on however deep the tumor goes in the sections you're seeing, and stage it accordingly. Obviously, if your deep margin is positive, then you cannot stage it adequately. Presence of LVI, tumor budding, or poorly differentiated cell clusters, and margin status are some important considerations. So one thing about these specimens is you have your mucosal margins, which are the lateral edges of the mucosa, and then you have the deep margin where the specimen has been resected from the deeper bowel structures. So presence of cautery is something that is very helpful in these specimens, and because these specimens are small, the ink tends to flow and may not be that reliable. Presence of cauterized changes is something you can look out for and report on. So here's an example. Here you have these cautery changes at the deep margin, which is reassuring that you are actually dealing with the true margin and not just the tissue edge. And obviously inking the margins is also very helpful in these cases, but again, the ink can overflow. So one important consideration in these local resections is the depth of invasion. So when you have a pedunculated polyp versus sessile polyp, your prognostication becomes slightly different. So for pedunculated polyps, you try to give the Haggett levels. So level 0 is where it's only in the upper part of the head, so without any submucosal involvement in the head or stalk. Then level 1 would be involvement of the submucosa of the head of the specimen. Level 2 is involving the neck of the polyp. and level 3 would be the stalk, and level 4 will be the actual submucosa of the bowel wall. And for sessile polyps, again, your submucosal invasion would be categorized in the SM levels. So to give the SM level, you would broadly divide your submucosa into 3 parts. So if your top 1/3 is involved, it is SM1. If it extends to the middle third, then SM2, and lower third would be SM3. Now, all the time for local resections, you will not have the complete submucosa. So giving an SM level can be extremely challenging, and you don't want your treatment decisions to be based off this parameter, which you are not confident about. So to bypass that, what we try to give is the depth of invasion. So for specimens which lack a muscularis propria layer, as I said, where you don't have the entire submucosa, you can measure the depth of invasion from the muscularis mucosae to the deepest part of the invasion. So that's a good alternative. And then having a depth of invasion more than 1 millimeter in the submucosa has been shown to have a risk of lymph node metastasis. And for these such local resection specimens, that is considered as a point in favor of going for a surgical resection. Sometimes your muscularis mucosae is completely destroyed, and you are not able to tell where the tumor started invading the submucosa. In those cases, giving the tumor thickness is a viable alternative. However, you should try to specify that this is not actually the depth of invasion, but you're giving a tumor thickness because you're not able to see the muscularis mucosa. And this flow chart essentially tells you the same thing, because whether or not you identify the muscularis mucosa or not. So moving on to another subtype of tumors in the GI tract, a main type is a neuroendocrine neoplasms. So, and it's important, right off the bat, you need to know whether you're dealing with a poorly differentiated neuroendocrine carcinoma or well-differentiated neuroendocrine tumor. And that distinction is very important because in addition to being associated with the worst prognosis for poorly differentiated neuroendocrine carcinomas, they are also staged just like your adenocarcinomas. But well-differentiated neuroendocrine tumors have a different staging criteria. So you need to make that distinction for multiple reasons. Unfortunately, we cannot go into the details of that, but here I'm showing an example of a well-differentiated neuroendocrine tumor of the small bowel. You can see these prominent serotonin granules. And this is an example of a poorly differentiated neuroendocrine carcinoma of small cell type of the pancreas here. So as I mentioned before, reporting of poorly differentiated neuroendocrine carcinomas is similar to other carcinomas of the GI tract. For well-differentiated neuroendocrine neoplasms, it depends on multiple other parameters. So when you have made a diagnosis of a well-differentiated NET, then the next step is to assess the proliferation index and or mitotic index for grading it. So Ki67 is the more sensitive one because it will detect cells in the G1, G2, and S phases of the cell cycle and in the mitotic phase. And because it's an immunohistochemical stain, then you can easily find hotspots rather than finding mitosis. But for these tumors, it's important to look at both because very rarely you can have a tumor which shows a lower labeling index but a high mitotic rate. And it can be your sampling or block selection bias, but you definitely have to look at both of these parameters and grade it based on whichever places it in the higher grade category. So for grade 1, you would call it grade 1 if the Ki67 index is less than 3% and mitotic rate is less than 2 per 2 millimeter square. If grade 2, if it's between 3 to 20% and mitotic rate is between 2 to 20, and grade 3 if the Ki67 is more than 20% and mitotic rate is more than 20 per 2 millimeter square. And then here's an example how you look for hotspots. So you try to find the area which is which shows the highest staining positive nuclei. And then the gold standard is taking picture of such an hotspot area and counting the number of positive cells against the background negative cells. So that has been considered the gold standard, manual counting, and you count between 500 to 2000 cells to get a reliable proliferation index. One way that people often do is just look at the slide and try to guess what it might be. So it's called the eyeballing method, and that's obviously not accurate. And then now we have various digital tools also available to automate your proliferation index analysis. So for staging of neuroendocrine, well-differentiated neuroendocrine tumors, again, as I mentioned, size is important. And then here's a brief overview of, all the neuroendocrine tumors involving various GI organs. And you can, go over individual staging schemes when you have such a case. But important to remember that for small intestinal tumors, you also need to give the size of the lymph node masses. So whenever you have mesenteric deposits or metastatic masses in small bowel neuroendocrine tumors, always note the size, because that is again important for staging in addition to the tumor size. And finally, moving on to GIST, very quickly, you definitely need to know and tell the clinician what type of GIST it is. Is it a spindle cell, epithelioid, or mixed type of GIST? And epithelioid GIST have more syndromic associations. They can have germline SDH mutations. So definitely you need to think about these things and be aware and do stains to make sure you don't miss that. For prognostication of GIST, you need to know the size of the tumor, location of the tumor, and mitotic rate. So mitotic rate is assessed in per 5 millimeter square. So for standard newer microscopes, it comes between 20 to 25 40x fields. So you would start your mitotic count at your first mitosis. So not just, counting 20 random fields and done. You start the count at the first mitosis and then start counting 20 fields and see how many mitotic figures you get. In the subsequent slide, if you feel that you may have a higher mitotic rate, you have to do it all over again. So if you have less than 5 mitoses per 5 millimeter square, it's considered low grade, and high grade if more than 5 mitoses per 5 millimeter square. And then sometimes you may also see necrosis in a GIST. So you have to give a percentage of the necrosis in such cases. It's not uncommon to see necrotic tumors in post-treatment scenarios. So important to be aware of that. And then again, when you have treated GIST, you have to give percentage necrosis and percentage viable tumor. And also be aware of important treatment-related changes in GIST, such as you can have reduced cellularity, you can see foci of hyalinization, myxoid stromal change, change in morphology from spindle to epithelioid, and pseudopapillary pattern, rhabdomyosarcomatous differentiation, or loss of KIT expression by IHC. So definitely these parameters you need to be aware of, and you would only give percentage of the viable tumor in such cases. So here's the risk assessment for GIST. This is taken from the CAP protocol, so you can go back and review it. So it depends upon the location of the tumor, gastric, duodenum, jejunal, or I think rectal. And then depends on the size of the tumor. So less than 2, 2 to 5, and 5 to 10 are the cutoffs. And then mitotic rate, as we discussed, less than 5 or more than 5 per 5 millimeter square. So depending on all these 3 parameters, you can get a risk category, which again will determine the further follow-up and treatment of the patient. So from staging point of view, size is important. So less than 2 centimeters is PT1, between 2 to 5 is PT2, more than 5 is PT3, and more than 10 is PT4. So finally, yeah, that was all I had. Sorry, I went over the time. I'm happy to take any questions. I'd like to invite Dr. Goyal for any comments or thoughts on this. Shall I stop sharing my screen?
Yes, ma'am.
Okay.
So thank you, Monica. This was a really nice educational presentation for I think, all pathologists. I was just wondering why Sumit actually invited me to be a chairperson. So as a GI surgeon, I can only offer my perspective of what we actually expect from a pathologist, which I feel is very important even from young pathologists. So
Yeah.
for me, the main important role of pathologist is in the post-op management. Of course, it's there in pre-op for diagnosis, but I think mainly it comes in post-op, where we actually rely very heavily on pathologist to tell us exactly what we are dealing with, which will decide our adjuvant treatment for that patient. And this is true for almost all GI tumors, let it be colorectal, even hepatobiliary, and now for that matter, even retroperitoneal tumors. So the margin status, especially in retroperitoneal, I can just give an example of a new emerging this thing is retroperitoneal tumors, where not many people have a orientation about that. There's no margin in retroperitoneal tumors. And in a free peritoneal cavity, when you report margin positivity, that may not be the issue actually. So, and another important thing which I want to say is that we keep learning from pathologists. The pathologists teach us a lot actually. For the way the field is changing, you have TNMs changing, which keeps changing. You have more and more immunohistochemistry markers coming in, biomarkers coming in. We don't even know the different type of histologies. So we keep going back to our pathologists. They tell us, okay, this is this thing, and this may be treated by this, or this thing will not work on this. The classical example is colorectal, where pathology decides whether the patient needs to, in stage 2, needs to take chemotherapy or no based on MSIs and all those criteria. So pathology is definitely a very important adjunct from surgeon point of view. And of course, they are already touched upon importance of grossing and synoptic reporting. So I was just wondering, just advise for all pathologists or young pathologists that if you ever get a chance to go to operate OR, please try and go to OR. That will help you in orienting yourself. So I think orienting a specimen is the most important. The first grossing is what is most important, which will lead you in right direction as far as pathology reporting is concerned. So I think that is my perspective as a surgeon, and I will leave it to the moderators to take all the questions.
Thank you,
Thank you.
Monika, ma'am. And thank you, Goyal sir. The talk was really beautiful, ma'am, and very informative and precise. Now we'll take the questions. So the
Thank
first
you.
question is, ma'am, can you please tell us what is quadricolectomy? Is it done even in benign pathological conditions?
Quadricolectomy. I have not come across that term. So I don't
Maybe
know if
sir can comment on that.
is it the same as total proctocolectomy?
Goyal sir?
Goyal sir has left the meeting.
Okay.
I think we can move on to the next question.
Yeah,
Okay.
the
I mean,
next.
let me, I can look it up, and then if sometimes,
ma'am.
we don't use the same terminology. So
Can we, ma'am, address it at the end of the other
yeah,
question?
let's do that. Yeah,
Yes,
we
ma'am.
can do that.
So, ma'am, the second question is by Dr. Babita, and she is asking, completely acellular mucin with no tumor cells, what RYAN score we will give?
So for treated tumors, is that for treated or untreated? So that makes a big difference for if you have a tumor that has been treated with neoadjuvant therapy, and if you see acellular mucin, that is considered as treatment response. So that would be, N0 stage. But in a treatment naive case, which has not been subjected to neoadjuvant therapy, if you see acellular mucin, that is considered N1 at the moment. I know there are some groups which are looking at this, and that the interpretation might change once the results of those studies come out. But as of now, we regard it as N1 if we see acellular mucin in a treatment naive case.
And the next question is, what closest distance from margin is taken as positive, whether it is 0.1 centimeter or 0.05 centimeter?
So it's 1 millimeter in theory, but whenever we have that, we say it's close and put in a note. So some of our surgeons, it's very variable. It depends on institutional practice. So based on literature, anything within 1 millimeter is supposed to be considered positive margin. But our institutional practice is going towards, calling them close and putting in a note to the same effect.
Then the next question is, for a submucosal neoplasm of colon that infiltrates into the adjacent organs, how will it be staged? And what is the minimum number of lymph nodes we should find?
So submucosal neoplasm, it would depend on the histologic type, right? Like if it's adenocarcinoma, then there has to be a precursor somewhere. So if I see an adenocarcinoma involving just the submucosa without an overlying precursor, I would definitely think about a metastasis from some other area, right? So, and then I would, in such a case, I would have a conversation with the surgeon or oncologist and try to find out if, this is a primary or met, depending on what they think, they can have imaging before we sign out our case. And for other, lymph node, it minimum is 12, but any number of lymph nodes that you can find is important for prognostication and staging. So lymph node remains the same. For other histologic types, again, the staging would depend on, for purely submucosal tumors, like, GIST or something else, the neuroendocrine tumor, then that would depend on, the size and other criteria.
Ma'am, the next question is, please clarify intramural vessel invasion, which layers are involved?
So intramural means it's still confined to the bowel wall. So you can have it in the submucosa or you can have it in the muscularis propria. So that would still be intramural. Anything beyond the muscularis propria is extramural, and that is more prognostically significant.
Ma'am, the next is GIST with indeterminate risk stratification, what to write? I think they are referring to in the report what to write. GIST with indeterminate risk stratification.
So the risk category as indeterminate, you just put whatever is you say risk category indeterminate.
Ma'am, there are no more questions. Ma'am, I have one question. Can I ask?
Oh, sure, absolutely.
Ma'am, mainly we get small biopsies, the small endoscopic biopsies. So, ma'am, in those cases for the histological grading in adenocarcinoma, can you guide as to how to say it is well? Because sometimes in some areas we see very poorly differentiated areas. Some areas we see very well-formed glands. So how to go about it?
So if you have a mixed morphology like that, and on biopsy, obviously it's not very reliable, right? You're only seeing a small part of the entire tumor. So I think any treating physician is aware of that. But if more important in those cases would be to talk about the poorly differentiated part, because that could change the management, right? So definitely, if you have any poorly differentiated areas, mention that. If you can say, if you have a bona fide well differentiated area and separate poorly differentiated, you can say invasive adenocarcinoma with well and poorly differentiated components. So I often do that, especially in the upper GI tract, right? You often get nice papillary adenocarcinoma, and then next fragment is just a sheet of poorly differentiated cells. But have a low threshold to think about neuroendocrine, because that is something that can really change the management, and something that you will not be able to diagnose if you don't think about it. So any poorly differentiated areas, think about neuroendocrine. With that thought, review the morphology again. Does it fit? Does it not fit? If I do the stains and if they come back positive, am I willing to say that there is a neuroendocrine carcinoma component? If you think the answer is yes, then definitely pursue that.
Okay. Ma'am, new questions have popped up.
Okay.
So the next question is, why do we assess budding hotspots in only H&E and not on IHC?
The answer to that is because the prognostic studies for tumor budding were done on IHC, on H&E stain slides. So if we start assessing that on IHC now, then it may have different prognostic connotations, right? So because IHC will definitely increase your ability to count tumor buds. But then if the original, you always try to follow the methodology that was used in the study, because you cannot apply those same parameters taken from H&E studies to IHC studies. So finally, if we get, IHC studies to validate the findings and, revise scores and stuff, then definitely we can use that criteria.
And the next question is, small biopsy, can we give specific diagnosis like mucinous carcinoma?
I usually refrain to do that because, you're only seeing a small sample of a larger tumor. So if what you may be seeing is mucinous, but rest of the tumor may be adenocarcinoma or something else, right? So what I say is adenocarcinoma predominantly with mucinous differentiation in this material.
I think Dr. Noshin, there are no more questions, right?
Yes, ma'am. Ma'am, Anita Borges, ma'am, has thanked you thoroughly for the talk. Thank you very much.
Thank you so much. My pleasure. And if anyone has questions, you can, you can reach out again by WhatsApp or email, and I'm happy to answer.
Yes, ma'am.
Thank you
And
so
I'm
much.
sorry for overshooting the time limit.
No, ma'am, it was very precise in context with how much you covered.
Yes, ma'am. We definitely.
Yeah, there's a lot. I actually had more slides on neuroendocrine tumors, but last night I was like, okay, I don't think I can, finish this in an hour. But yeah, but yeah, any questions, please let me know, and happy to answer.
Sure, ma'am. Thank you, ma'am.
Okay, thank you so much. Good night, everybody.
Thank you, ma'am.